favoured that over intraosseous, but clearly, if you can't get an IV access in, intraosseous is your second choice. And then identifying and treating reversible causes early. And the only other thing we've done is given a greater emphasis on just doing important things right. So putting the apical pad in the correct place, so just under the armpit, as opposed to most ones I tend to see, which are somewhere on the front of the chest. So lots of important things, but overall, no big changes.
Great, thanks, Jazz. And we're going to get into some of these details as we go through the slides as well. Michael, any extra comments or any additional comments on process or the algorithm that's been derived by the AHA group?
Ian, thank you. I'm going to hand this to Jane.
Okay.
So with regard to the AHA 2025 algorithm, the core algorithmic steps are the same. You'll notice, though, that there have been some changes in the ALS guideline in that we have taken out special circumstances, and that's gone to its own chapter. And we have also moved post-cardiac arrest care to its own chapter as well. You'll notice, though, that on the right-hand side, we've got a new margin that has key clinical performance elements that include things like dosing, shock energy, and reversible causes, which make it really easy for people to access that information when they need it. So it has a little bit cleaner flow this time maybe than 2020. And also, we've put capnography into a little bit more prominent place. It's not just in a footnote this time. It's actually within the algorithm. And as I mentioned, you won't see post-arrest care in this algorithm.
Great, thanks, Jane. Okay, so what we've done is we've highlighted some of the key differences or some of the key more controversial areas within both the ERC and the AHA guidelines. And we're going to have some discussion from our experts at the front here around how they came up with maybe some of the slight nuances of their specific chapters. So I'll take the first one around advanced airway placement. Maybe I'll throw it to Jazz and Jerry from ERC and just maybe a little bit of insight into how you came up with your recommendations around intubation and advanced airway management for experienced providers.
Yeah. So Jerry's going to cover this.
Perfect.
And it does build from basic life support, where people could be doing no airway management, compression-only CPR, and then a stepwise approach into this advanced airway management.
I think the most important thing is that we, and I think the AHA have done the same, very much tried to be consistent and follow ILCOR treatment recommendations, and there's been a lot of work on this in terms of certainly tracheal intubation versus supraglottic airways, for example. So I think where we have been fairly clear that if an advanced airway is required, tracheal intubation should only be undertaken by experienced providers, and we actually define that by providers that are capable of intubating the first attempt in 95% of cases, and with the maximum of a 5-second interruption of chest compression. So that really defines a very high bar for these providers to actually undertaking tracheal intubation. Otherwise, they really should be using supraglottic airways.
Thanks, Jerry. Michael's AHA side, would you say that sort of follows the same thinking, or are you taking a bit of a nuanced approach to that as well?
No, I think we follow virtually identical thinking. Our audience for the AHA is primarily in the United States and in North America, and so with that we have and our audience is really lots of pre-hospital providers, the vast majority. I think the nuances come from the idea that the EMS systems in North America are fundamentally different than they are in Europe, and so it is very uncommon to have a provider in the field who can meet the bar that Jerry and Jess spoke about, right? A 95% first pass rate, right, with a minimal 5-second interruption is an incredibly high bar. And so with that, there's, I think, in the AHA guidance, certainly the ability for experienced providers who are successful to do endotracheal intubation, but there is more equivalence given to the supraglottic airway simply because we have many providers who will go a very significant amount of time without providing that psychomotor skill.
Great, thank you. Jazz, something to add as well?
Yeah, I was going to say that when we look at the observational data from North America and lots of parts of Europe, that change has already happened in that most advanced providers are already using supraglottic airways as their first choice airway. And the other thing I was just going to add, as for the AHA, if you're going to intubate, you've got to be using waveform capnography to confirm you've put the tube in the right place, because the two dangers of tracheal intubation are, one, lots of hands-off time, and secondly, putting it in the wrong place and not realising.
That's a great point as well, and we highlighted that as part of our second one on there, that in the ERC it says you must use waveform capnography as part of your intubation attempts. Michael, Jane, anything on the AHA side? I know there's a recommendation for it, but...
There's a recommendation for it. We would absolutely agree. The reality is that we have a number of EMS agencies that simply don't quite have the technology yet. And so in order to be cognizant of those perhaps lower resourced agencies, we were afraid to perhaps make a line in the sand there, and so it's highly recommended.
I think also with regard to waveform capnography through the AHA, we look at capnography throughout the whole resuscitation, and it's used if it's available. But some of them are still using color change.
So this is a really interesting area, isn't it? It's quite controversial, this, and we've had a lot of discussion because we are very similar, but we are saying mandatory. If you haven't got waveform capnography, you don't intubate, which is quite a hard line, but there is a very large body of experts who would support that now, certainly in the sort of airway management world.
Absolutely agree.
Excellent. And I guess speaking of end-tidal CO2, one of the other common reasons for using it is to help monitor CPR quality. And, it's becoming a thing that people have used a lot, both pre-hospitally and in-hospitally, to determine how good your CPR is. And I see both groups have added some numbers in there that aren't quite the same, but there's some numbers around what this looks like. And so maybe you guys could discuss the process around coming up with the numbers you did to say using end-tidal CO2 for your CPR quality.
So Jerry chose the numbers for the ERC guidelines.
So this is really interesting because I've just looked this up. So just to be clear, we've suggested if you're going to use sort of physiology-directed CPR, then perhaps we should be aiming for a target. The ERC target is an end-tidal CO2 of greater than 25 millimeters of mercury, whereas I think I'm right in saying the AHA one is 20 millimeters of mercury. Now, the reason I'm smiling is because we took our figure of 25 from a figure that was published from an AHA scientific statement in 2013. They used the figure of 25. And to be honest, that's why we come up with our figure. So I'll perhaps pass over to you to explain the 2020 figure you've got.
So the numbers, the numbers that we used were from the scientific evaluation that we did, kind of soup to nuts this time. It was encompassed some more science from after 2013, and I think that's the reason for the change, simply because the author of that worksheet was a young investigator who was very diligent and went back very, very far, not just to the last set of guidelines.
And just having looked into this myself, that's absolutely correct. And in fact, specifically, it's some pediatric data, I think, some pediatric observational data, which supports, in a way, that figure of 20. So that's an interesting...
I was going to say, so in the ERC guidelines, we have certain targets, such as the 5 seconds for hands-off time for intubation. But we do realise that they're aspirational for a number of rescuers, but you've got to be pushing those boundaries, and if people are aiming for 25, they're going to get a highest. They may not get to 25, but we are pushing these things, but do realise that not everybody might achieve them, or it may not be feasible.
Yeah, I think it's the principle, right? The principle of aiming for higher end-tidal CO2s, regardless of kind of that number. So, and the other one that comes up a lot more now is around more settings where you have more advanced monitoring and the ability to use diastolic blood pressures and other blood pressures to guide your your resuscitation. And again, in that case, the ERC's come up with a specific value as kind of that lower threshold. And I know the AHA has made recommendations around it, but maybe not quite come up with the values. So maybe just a bit of discussion around how you guys came up with the value at ERC.
Yeah, no, I'm happy to take that. I mean, I think, again, it's a similar concept where we really want to try and aim to sort of surpass these threshold values if we can. That figure is taken from, again, it's one of these strange areas where actually we're taking the science from our paediatric colleagues and putting it into the adult world. So those were some figures that came out from observational data from the paediatric world in larger children. Suggesting that. I think the interesting thing about using diastolic blood pressure in that way is there is some debate or controversy around exactly how you measure that, and that is a body of work that needs to be undertaken in a lot more detail. But I think the pragmatic view is if you've got an invasive line in, it's probably sensible just to take it from the monitor, and I believe that's what some of the experts in the US are doing at the moment.
So this was one of those topics where the scoping review, all these guys are in ICUs, operating theatres, even in pre-hospital critical care settings, people are putting in arterial lines and doing continuous monitoring. So we've given them a target, but in the small print, we've said it's actually quite hard to measure in real time and use. And we know that teams who use this tend to just use the diastolic number displayed on the monitor, which may not be the scientifically correct diastolic blood pressure, but it does give you something to aim at or try and increase.
Yeah, thanks, Jazz. Jane and Michael, I know AHA side as well, there was a lot of discussion around this topic and some recommendations, but no specific number that was reached as a consensus. Maybe just a bit of insight into some of those discussions and why it was decided to take more of an approach that didn't give a specific value for it.
Again, this relates, I think, to the huge pre-hospital non-critical care audience that the AHA guidelines go to. It is rare that there's anyone in the field who can either place or monitor or knows how an invasive line works, right? It is only in, even outside of the emergency department, it's only really in our ICU settings where we have arrests that are monitored in this manner. And so while I appreciate, Jazz, what you say, right, like it's an aspirational target, what we wanted to prevent, the reason for this is we wanted to prevent the impression that CPR or defibrillation or drug management ought to be delayed so that a provider could slide an invasive line in. Right, and take away and somehow take away from the evidence-based care that we know. Again, I think it's just a difference in the audience.
Yeah, great, thank you. Speaking of blood pressure and increasing blood pressures, epinephrine, vasopressor, there's a little bit of difference in terms of timing of vasopressor use within the guidelines. And so maybe if you guys could speak to that. And I think within those as well, there's maybe a little bit, there's some other recommendations around, secondary vasopressors like vasopressin and those types of drugs. And so maybe a double question around vasopressor use within the guidelines.
I'll let Mike go first because the AHA gives the vasopressors earlier for shockable rhythms, so you can shock everybody with the reason.
Yes, so the goal is to get the vasopressors on as fast as possible, and that's hopefully immediately after, the defibrillation occurs, and then an emphasis for it early and often in the non-shockable rhythms. There's also, I just want to highlight, in the United States we have a number of, the reason for this again, in the United States we have a proliferation of a number of methods of administering epinephrine or adrenaline in the pre-hospital space. We have some folks limiting the amount. We have some folks giving drips. We have some folks giving IM adrenaline or epinephrine. And so this is an opportunity for the AHA, again, because of the audience, to kind of have a standardized approach to this.
Yeah. So the ERC guidelines try to separate out shockable and non-shockable rhythms, and our interpretation is that for shockable rhythms, adrenaline might be bad. For non-shockable rhythms, the paramedic trial suggested early epinephrine was best. So that's why we've sort of created the gap. So giving 3 shocks and high quality CPR, and then only then giving adrenaline and amiodarone once you've given 3 shocks. So that's the prime reason. We've also, based on the recent IVIO trials, de-emphasised the use of intraosseous access in our guidelines, because if people can do IV, they should do it, and only when they can't should they consider IO, because there was a signal for IV being better in 2 RCTs.
Just to add to that, I think a subtle difference around the IVIO is we sort of specify 2 attempts at IV first and then only going on, so we give a sort of very clear number, which you could argue about.
Which is what they did in the trials.
Yeah.
Yeah, and we didn't specifically specify how many attempts, because I think that while we concur on so many things, I think that the difference, one of the big differences that drives our differences are because of the huge EMS population that we're dealing with, and it's just a very different group of people who are taking these guidelines.
Great, thanks. And I guess just to clarify, based on Michael's excellent comment, that this discussion is around IVIO epinephrine and not into the IM epinephrine and the epinephrine drips, right? Yeah.
Yeah, I think IM epinephrine is too early to call and needs proper trials. I think one of our values and preferences is on IO was it probably costs more money, and we don't want people leaning towards IO when there's a signal that IV may be better. But I wouldn't expect people just to learn IV so they can do CPR. Hopefully people who do IV during cardiac arrest have learned it for other reasons.
Excellent, thanks, Jazz. All right, so let's talk about something less controversial and double sequential defibrillation, and where the guidelines have ended up with that. So obviously new evidence has come out since the last iteration of guidelines. Both ERC and AHA have landed somewhere in the same ballpark in terms of how they feel about double sequential and vector change defibrillation, with some differences in wording. But I'm going to start on the AHA side. But Michael and Jane, how did you guys end up where you did to suggest on the AHA side that the usefulness of using double sequential has not been established?
Yeah, so we had a lot of discussion within our group about this, on and on and on and on. And it was a very good discussion, but in the end, the group decided that there needs to be more data on this, and also more data on double sequential and on vector change as well, not necessarily together.
Yeah, I agree. I don't, there's, I think, some semantic differences in the wording here between the 2 groups, but fundamentally what we're saying is we're not sure that exactly what's occurring, and we're not really sure that this should be done certainly as the first or second line preference. Embedded in double sequential defibrillation is the idea of the change in vector, right? And so it's very unclear which technique, whether it's just more juice, right? It's just more joules being delivered to the heart in kind of the same period of time, or if it's actually the vector change, the roughly same amount of electricity being delivered from a different direction that is actually the determining factor in the success that's seen in the trial.
Okay, thank you. And on the ERC side, Jerry?
Yes, I think we took a fairly pragmatic approach to this. The first thing to say is actually vector change was in our previous guidelines. So the suggestion was if you were still in VF after 3 shocks, consider changing to an AP position then. So we already had it in there, which is why the subtle difference is we are veering towards suggesting vector change in shock refractory VF and not dual sequential. So we've actually sort of put one above the other, whereas I think you've put them both at the sort of same level of uncertainty. So that's the subtle difference.
Great.
Yeah, and we don't want people messing around with 2 defibs when they're not probably using the first one properly. We want them to focus on getting their first good 3 shocks in and then thinking ahead. And so I think there's only one RCT, stopped early, it's to me and to our working group and writing group, it didn't quite, hit the mark for making a decision for DSD. I know there's a lot of advocates of it out there, but it's not ready for prime time or for the ERC guidelines.
And I think that in addition to that, as we do think about this more and more, that technology may play a big role in this. And so I think that that's something that our group thought also would be forthcoming in the future.
Great, thank you. Oh, last thought, Michael? And then
Just
we'll,
real quick,
yeah.
so Jez, I absolutely agree. I think sometimes often part of the reason why we don't have shock success is the pads are in the wrong place, there's poor connection, there's any number of reasons rather than move to double sequential. And then frankly, when you look at how double sequential defibrillation has to be delivered in order for it to be marginally more successful, right? And we're talking about the shocks being delivered within millisecond windows of each other, right? There's a certain amount of technology that we don't have yet to be able to deliver it optimally.
Great,
and it is literally two people just hitting the button at the same time.
Great, thank you. We got about 5 minutes left for discussion, but I do want to hit on another topic that I think is increasing in popularity, but maybe is jumping ahead of some of the evidence behind it, and that's just the use of point-of-care ultrasound during cardiac arrest for things like establishing an etiology of arrest, and just whether both groups had a bit of a high-level discussion around what went into making some recommendations around using or not using that technology.
I think for the ERC, we've always had consider use of ultrasound, and if you read the small print, you've got to have it, and you've got to be able to do it with minimum hands-off time and not interfere with all the other things like giving shocks and so on. So we've not really changed. We've not, overemphasized it or underemphasized it, although I know, I trained a long time ago, and I'm a newbie to ultrasound, but all our residents, carry one out. They use it a bit more like a stethoscope, so people are going to use it, but if you're going to use it during cardiac arrest, it's because you've got really good at using it for all your other work, and you can do a quick image and not slow down all the other things. So I wouldn't learn ultrasound just to use it in cardiac arrest.
Well said. Michael, Jane, any additional comments from AHA?
I think the additional comment that you mentioned, Jazz, it is incredibly operator dependent, right? And it's about how much skill and expertise you have in using it. It's kind of like intubation in that regard, right? And so, it's not as it's the you miss the tube and it's catastrophic and tragic. If you don't get anything from the ultrasound, what's the downside? The downside is you've interrupted CPR for however long you've done it, and we know that's also an evidence-based way to resuscitate people. That's really the downside to using ultrasound. In good hands, yeah, it can be done.
Yeah, excellent. Okay, a couple more topics before we take questions from the audience and the online audience. Reversible causes. So there's one discrepancy in there. What's the discrepant reversible cause between I guess two, one H and one T? So
we've put pulmonary and coronary thrombosis as one, and we don't have hydrogen ions because we don't want people giving sodium bicarb, and I don't know how you can reverse hydrogen ions apart from restarting the heart or something. So and we've specifically said don't give sodium bicarb, but we've always had 4Hs and 4Ts, so why change now?
I think that for the AHA that the gist and the meaning of what we've done is really very much in line, and we've just parsed it just a little bit differently, but I think that the gist of the meaning is the same.
Okay, so the reversible causes are sort of the same then. Okay, good. All right, and maybe I'll go to Jazz and Jerry on the CPR-induced consciousness, just because you and the ERC have decided to make a recommendation around CPR-induced consciousness.
So this was, again, from a scoping review, scoping process where quite a lot of EMS and people were saying, oh, what do we do if a patient starts moving during CPR, but they haven't got ROSC? And as people have used mechanical devices, or especially with professional rescuers, patients start moving, and it's happening in about 1% of cases. And so all we've said is, if you can, and most people may not be able to, give them tiny doses of painkillers or things to help sedate them, but not too much. And don't give them paralytic agents without sedating them. So that's the guideline. But it was an answer to, lots of people asking for it. And if you sort of Google or look on PubMed for CPRIC or CPI-induced consciousness, there's more and more papers and more people reporting it.
Excellent. Michael and Jane, was there discussion at AHA level for this topic?
There really wasn't,
Yeah.
because we didn't have a PICO, and I think the ERC approach to the public comment is unique.
Yeah, I think there is an ILCOR scoping review on it from a few years ago with an evidence update. So the information is out there with a good practice statement, which we followed, I think.
Excellent. Just because we're getting really short on time, we have we've already covered IVIO insertion. We have 3 topics that were left on the board. I don't know if I might leave it to the expert panel at the front here for the ones you want to discuss the most. We have steroids during cardiac arrest, ventilation quality, which is obviously a big topic. And then we have one down at the bottom around our bradycardic algorithms and epi infusions versus push-dose epi, which has worked its way into the AHA algorithms.
I think ventilation is the topic that we've put more in the ERC guideline this year. And I think there was the data from one of the big ROC studies, which was showing patients are actually, in the 30-2 trial and the versus continuous compressions as ventilations, patients actually got very few ventilations per minute. And there was another paper, I think somewhere from Europe, where they were doing mechanical CPR, again, where patients actually got very few ventilations. And so a value and preference of the ALS working group was, so if you've got all these people getting compression-only CPR, so they've not had any oxygen or ventilation, and then the ALS providers come along and do terrible ventilation, you're on a losing. I'm going to use a cricket analogy because it'll confuse half the world. You're on a losing wicket.
Michael, you need to come up with the baseball version.
I was just trying to see if I could come up with an adequate baseball analogy for this. No, I think the paper you referred to from the ROC study, I'm not familiar with the European one, showed that in that 30-2 group, less than half of the folks ever got an adequate ventilation, and that if you got even 2 adequate ventilations during that time period, your chance of ROSC tripled. Right? And so, yes, I think it's incredibly important that with the shift, we've gone from, 10 years ago, we went to CAB. And so, like you said, yeah, there's all this compression-only CPR occurring. And that's wonderful if you're a bystander or you're not a professional and don't have the equipment to provide respirations. But certainly, once the professional rescuers arrive, we ought to be, it should not be an afterthought. We ought to be concentrating on quality, adequate respirations during CPR.
Yeah, fantastic. Thought on that, Jerry? Or
just very brief. Yeah, no, very brief thought on that. That is, we're seeing now technology that is enabling us to monitor exhaled, expired tidal volumes as opposed to what we think goes in. And I think, therefore, in the future, we will be able to determine, what is high-quality ventilation, monitor it and deliver it effectively. Because at the moment, most of the time we don't know. Somebody says they squeeze a bag. Did they actually get anything in the chest or not? Don't know.
Great point. Jane?
And I think that we put in avoid excessive because it hasn't been that long ago when people used to think more oxygen, more ventilations, and deeper ventilations were always better. And I think that we put that in just to make sure that we put the punctuation mark that we need to remember that it needs to be great ventilations, but it doesn't necessarily need to be 40 a minute like we used to see.
Not necessarily more, just good. Yes. Yeah, right. Excellent. Okay, we'll stop the discussion there. Thank you very much to each of our panelists up front here for their insights into the guideline recommendations. What we're going to do is we're going to take some questions. We have time for questions from the audience here. And if you need time to think, I also have a good list of stuff that's come in from online as well. So you want to start in here, Peter?
Yeah, sure. Thank you. Morley, Melbourne. I guess I want to explore the targets for end-tidal CO2, possibly diastolic at the same time. So if someone's got an end-tidal CO2 that's, 19 with the AHA or 24 with the ERC, what are you expecting them to do? Do they compress deeper than recommended? Do you compress faster than recommended? Do you change your hand positions, or do you wait to get a toe to do that? Do you decrease your ventilation rate so as you're not clearing it as much, or do you stop, or do you put them on eCPR?
Great. You've covered the things we were going to do on our research slide that we didn't have time for, Peter. So for most rescuers, they're just going to do 30 to 5 to 6 centimetres. But if you then have all the protein, because rescuers like athletes, some of the Olympic gold medalist type rescuers will have all this info, and they'll be able to change hand position, nuance it. They may titrate their adrenaline dosing. They may make adjustments. So if people are capable of doing that, they may be able to get that end-tidal CO2 higher. And if you've got an arterial line in, they may be able to get the arterial diastolic pressure higher and so on. So depending on the rescuer and the patient, you may achieve these goals, but we do have to accept it's not always possible.
Peter, to that end, I think the most important intervention, and the only one that you didn't mention, is that maybe you need another rescuer, right? So if you can't quite reach that number, maybe it's because the rescuer who's doing the CPR is fatigued, and maybe you just need a second one, in addition to all the other things you mentioned.
And directly linked to that, and a direct answer to your question, depth is a much bigger determinant of end-tidal CO2 than rate. And there's a few studies showing that quite well. So I would say to you, it just aligns with what you just said, really. Get somebody that can give a bit more depth if possible.
Because depth is the first thing that goes when you fatigue. It's depth and then rate and then, yeah.
Great, thank you. Just on that topic, just while we're here, I have a question online about whether you would recommend using waveform capnography with just bag valve mask ventilation, or do you wait until there's an advanced airway?
Okay, so that's a really good question, and actually we should extend that to include supraglottic airways,
Sure,
because
yep.
people will ask about that as well. I think the supraglottic airway question is yes, because I think there's actually quite a lot of data out there now suggesting that supraglottic airways will give you almost as reliable or end-tidal CO2 as tracheal intubation. I think bag mask, I don't think we have the data out there yet, but clearly there is an issue there, because you're much more likely to have mask leak, you're much more likely to have probably artificially low CO2s. So the short answer is I would not reliably be considering using it for that reason. Remember, one of the reasons for waveform capnography is, number one, confirming tube location if you intubate somebody, as well as all these high. And that one is, there is far more certainty around the need for waveform capnography. All these other things I think are secondary.
Fair. Any other thoughts from anyone? No? Okay. Marcus.
Markus Krivas, Helsinki, Finland. So what's your advice on the patient that has a cardiac arrest in the cardiac care unit or in the ED who has a monitored ventricular fibrillation where you can shock right away? Do you recommend 3 stacked shocks? And how about the adrenaline? Should you give that very early? And how about the antiarrhythmic agent? When should you give that?
So the ERC guideline has a specific thing that rather than doing 1 shock and 2 minutes of CPR, you can give up to 3 stacked shocks, because I think quite a lot of the older observational data shows that if you do get VF that early, the chances are one of those first 3 shocks will be successful. But clearly if they fail, those you need to carry on with the algorithm. But for the purposes of adrenaline and amiodarone dosing, we ummed and ahed about this, and ultimately we've just said those, if you do stack shocks, they just count as the first shock in the algorithm. So you'd have to give a couple of, 2 minutes of CPR shock, 2 minutes of CPR shock, and then think about adrenaline and amiodarone. But I think we changed that a while ago, because cardiologists who were getting VF in the cath lab was saying, there's no way we're not going to give 3 stack shocks. So you have to give your guidelines have to fit your market, and our market wanted 3 stack shocks for witness monitored arrest in these very specialist settings. So we didn't want to, another British phrase, piss them all off. Is that a level of evidence?
Is that British?
That's the level of evidence.
Jane, go ahead.
I think it's a wonderful question, and the AHA has answered that in special circumstances, not in ALS this time.
Great.
Do you want to comment on that? I think you asked about epinephrine or adrenaline under those circumstances. In the VF situation, it's difficult. Certainly if you've got a monitored cardiac arrest in the context, a lot of work we've done is around intraoperative, for example, where highly monitored patients. And we do then suggest that if you witness it with an arterial lining, for example, you're in straight away. We do talk about then titrated adrenaline, titrated epinephrine, using 50 to 100 microgram doses, because giving a whole milligram of epinephrine under those circumstances, as you well know, is likely to result in a massive increase in pressure, and you may well get a pulse back very easily with smaller doses. Where is all the evidence for that? I think it comes from experience, observation, what's actually happening in practice. But it's a very difficult area to give firm guidance on.
Thanks, Jerry. While people are thinking in the audience of additional questions, I have some rapid fire stuff from online, a lot of good questions in from online, that will actually cover off some of the topics we didn't get to before, all around drugs, so your thinking cap on. I have a question around beta blockers alongside epinephrine and whether you've made mention of that for refractory cardiac arrest or refractory cardiac arrest.
We've looked at it for the ILCOR systematic reviews, and the hype massively exceeds the evidence, so they're not in the guidelines.
In the AHA guidelines, we addressed a number of these, we'll say, alternative drugs. In the U.S., Bertilium has just come back on the market, and so and so we addressed that beta blockade. Off the top of my head, I can't remember the rest, but and have exactly the same response, which is the hype is significantly larger, or in the case of Bertilium, significantly higher than the evidence. And Bertilium, it's essentially non-existent.
Yeah. That's great. Some of those other tertiary drugs are in here. So the next one I have is around evidence around bicarb.
Yeah, this is one of the big controversies, and it's an area that I still think is ripe for further studies, actually, because most of the evidence comes from old studies, and when we've sort of synthesized all that evidence, certainly at the ILCOR level, our feeling is that it is not something that should be given routinely in cardiac arrest. So that's where we stand. So we've aligned with ILCOR, pretty sure that aligns with the AHA as well. So at the moment, the answer is no. But I think it's high up on the list of interventions that absolutely should be studied using modern, robust scientific techniques, because I think there's uncertainty about it.
Great. Any other comments? No. Calcium, and I know we had steroids on there, so we'll do both as our last two kind of tertiary drugs, but any evidence around giving calcium during cardiac arrest and then the use of steroids?
There is a large Danish study which showed it didn't work, potentially harmful. So again, calcium's one of those drugs that shouldn't be given routinely. A lot of people like it, but it could be harmful, both in terms of ROS survival, brain injury. So unless you've got a very good reason for doing it, like severe hypocalcemia, calcium channel blockade, or something like that, it's not for routine use.
Comment or question?
Question.
Okay. Just, steroids? Any role for steroid?
We looked at, so there's essentially 3 trials out of a European, I forget the group, if it's Greek, I think it's Greek, out of a Greek group that have never been able to be replicated outside of that one study group. And so we essentially took the position that they shouldn't be used.
Yeah, another area for trials, because people have thought they may improve post-ROS, get rid of shock and so on, but the trials are hard to actually translate into something useful for everyday use, and So and there's different steroids, different time points that are given, different combinations. So some of them are vasopressin plus steroid. And there's too much noise in those to make actually a clean recommendation. So more high quality studies needed, but someone needs to actually work out what the intervention should be and when it's given.
Great, thanks, Chaz. One quick question for the AHA folks from online. If bradycardic algorithm and the introduction of push-dose epinephrine, do you have recommendations around how much push-dose epinephrine you would give if you're not going to give it an epi infusion?
I think that it was more about the method of giving the epinephrine.
Okay. Less so about the dose.
Less so about the dosing. I think
Okay.
we're all kind of in a, I think those who have had experience with that, either in the operating room or in the ICU, would titrate that dosing rather than just a fixed dose to go. I think it's more about the method.
Okay, excellent. We'll take one last question from Marcus.
So you emphasize the importance of high quality chest compressions. What's then the guideline stance on mechanical chest compression devices?
Threw in a big one right at the end.
So mechanical CPR's had 3 large RCTs that has never shown a benefit in routine use. And I think the issue is that everybody who gets mechanical CPR usually gets some standard CPR first. There's the transition. There was a signal of potential harm for people with shockable rhythms. If you should be shocking them, you don't want to waste time putting them on a machine, etc. So the ERC guidelines emphasize the use in those situations where high-quality manual CPR isn't feasible or possible due to transport access, transfer to the cath lab, or transition to ECPR or ECMO. So not for, people shouldn't be buying them for just everyday general use. You want to have a good niche reason to use them. And I think their use has grown during COVID because it meant you didn't have to be close to the patient. You could just connect them to the machine and sort of stand back. So I think their growth in their use has increased. But if you're going to do it, you've got to have a good sort of Formula One pit stop drill to actually put someone on the thing, so you don't have a lot of hands-off time and you don't miss your goals like early defibrillation, drugs, and so on.
So that's covered in another chapter. That's covered in BLS
It's
with
true.
the AHA, but I absolutely agree that it does need to be a pit stop drill if it's used. And but in places like Texas, we have such long transport times, and there are so few people in the back of the box that I think that is a special circumstance where it is super important when you have 30-minute transports and one person can't do CPR for that period of time.
That's great, thank you. I said it was going to be the last one, but I have one very short one that I think is important. I know, they're hammering you with questions. Is there anything about tibial versus humeral IO if you're going to recommend doing IOs?
The Danish study, I think, has published on that, and I thought humeral IO would be better than tibial, but their data actually showed it the other way around, and we don't. So tibial was better than humeral. Neutral. There was no difference. No difference. But whether that's because the humeral's harder to put in or not, I'm not sure. Yeah. So it's
To be determined.
To be determined. We've not specified where to put it. As long as you put it into the bone marrow.
Yeah, perfect.
Go for the IV first.
I think
Right.
I think the important thing is that there was a school of thought that you could perhaps deliver a drug quicker into the central circulation using the humeral route. And although ASCA has pointed out that trial was neutral, it was interesting. They had, I think I'm right in saying, ASCA, a high number of misplaced devices in the humeral side, certainly relative to tibial. So there may be an issue with getting it in the right location.
That's what I remember
humerally.
too. Yeah.
And displacements was the other issue actually afterwards.
Great. Thank you very much to our panelists. Great discussion.
Thank you.
All right, we're going to do a quick swap here. We're going to get our post-arrest committee to come up to the panel table. As they come up here, as we're doing our swap, if you're online still or you've just joined, the Slido worked very well. And we're going to use the same Slido for the next part of the session as well. And so we'll be monitoring that. So if you have questions that come up and you're online, please feel free. We have lots of room to ask lots of questions. So please feel free to use that. And same thing in the room here. We'll just take questions verbally as well. As they're getting settled, so we're going to do the same type of format. We'll have 30 minutes. We'll just discuss some of the key differences, some of the key maybe controversies, and some of the key components of the post-cardiac arrest care chapters. And then after that, we'll open it up for discussion. You guys can let me know when you're ready. The far end of the table looks ready to debate. It's good? Yeah. Okay. Excellent. So I will, again, everybody knows who I am, but I will introduce our panelists for the post-cardiac arrest chapter. Maybe, John, we'll start with you.
So, hi, my name's John Rittenberger. I'm an emergency physician with the Guthrie Clinic, and so I'm one of the authors for the PCAC chapter. Vice Chair.
Hi, I'm Karen Hirsch. I'm a neurologist, neurointensivist from Stanford University in California, and I am the chair of the PCAC chapter.
Hello, I'm Claudio Sandroni from Rome, Italy. I'm an intensivist and a member of the ILCOR Advanced Life Support Task Force, and I'm a senior co-author on the guidelines of post-resuscitation care from the ERC.
My name is Markus Krivars. I'm an intensivist anesthetist working in Helsinki and also affiliated with the University of Helsinki. So I'm author on the ERC, ESICM guidelines, and also a member of the ALS task force.
Great, thank you, everyone. So starting off with just some major updates to both of the guideline chapters, and I'm just going to go through these quickly, but we are going to focus in on some of the more nuanced details of these when we get into our discussions. So both guidelines, both AHA and ERC, recommended whole body CT scans after ROSC to identify treatable causes, and the AHA also recommended ultrasound. They recommend mechanical circulatory support for post-ROSC shock, and both guidelines recommended treating seizures in the post-cardiac arrest patient. The prognostication of good outcome was added in addition to the standard prognostication of poor outcome that was already there. And the oxygen and blood pressure targets have both been updated based on new evidence over the last number of years. Finally, there's been a greater emphasis on the rehabilitation and family support portion of post-cardiac arrest care, and the AHA has also added a section addressing burnout in healthcare professionals. So quite a number of changes to, or updates and changes to both post-cardiac arrest guidelines in both guideline groups. Claudio, maybe I'll pass it over to you just to give a quick update of the ERC algorithm.
Yes, this is a general ERC algorithm. So it's rather complex. So we'll just summarize the most important changes. There is a more explicit recommendation to delay coronary angiography if the clinical context does not clearly indicate a high likelihood of acute coronary syndrome. And in these patients, a whole body CT scan with pulmonary angiography should be considered. And as we said, we should consider mechanical circulatory support for persisting cardiogenic shock in selected patients. We added more emphasis on EEG recording, which is very important not only for prognostication but also for treating seizures. We added a completely new prognostication algorithm, which is an algorithm per se, so we have a separate algorithm for that. There are new recommendations for a comprehensive diagnostic workup, including genetic testing, cardiac MRI, sodium channel blocker tests, exercise testing, and it is in the lower left corner of the algorithm. We'll show it later. And there is a more emphasis on long-term follow-up, rehabilitation, and family support. And as an additional note, as you can see on the right-hand side, there is a AHA algorithm. So the two clear differences is that the AHA algorithm is divided in two, while the ERC algorithm is divided in three phases, but the dashed red lines show that actually the steps are exactly the same. So regardless whether there are or not minor differences in the design, the steps are comparable.
Great, thank you. Karen or John, any additional details on the AHA algorithm you'd like to discuss?
I think the only thing that I would add is for the end user, just like you heard from the ALS algorithm, we try to keep the algorithm itself pretty simple and straightforward so someone can pull it up real time and look at it. But the boxes to the right are certainly to be used as references to see additional details.
Great, thank you. All right, let's get into some of the controversies. So the first one at the top there, so I don't know if it's super controversial that you guys have picked different SpO2 targets because they overlap quite a bit, but maybe you could give the readers some insight into how we came up with different targets based on the evidence available for post-cardiac arrest SpO2.
So of course, oxygen is all these patients receive oxygen, and the oxygen target is important. And we've of course always discussed this thing about oxygen radicals. So that's why there's been this idea to perhaps we should target lower oxygen. But I think the best evidence and the reason why the ERC recommends 94 to 98% is the Australian EXACT study, where they randomized about 450 patients to a lower saturation target of 90 to 94% or to a more liberal target. And then there was a clear signal for harm in the lower oxygen target group. This is, of course, the pre-hospital setting. It may be different in the ICU when you have an ART line, or in the ED when you can check PaO2 values. So that may be a caveat there. But that's why we decided on the 94 to 98%.
Okay, thank you. And John, AHA went down to 90?
Yeah, so we largely went with kind of the entire body of the literature that largely kind of ranged anywhere from 90 to 98, and we kind of stayed with that and didn't parse it out based on one specific study.
Excellent.
I just want to make a quick comment on some, I think, slight methodological differences too between AHA and ERC. So for the AHA process, we were very constrained, if you will, not in a bad way, but just constrained by sticking very closely to the available literature and using specific wording around the AHA core and LOE. And so while you may see some very subtle differences here, I think a lot of times it's just reflecting slight methodological differences between how we approach these things. So just wanted to note that as we get into some of these nuances.
That's a great point. Any other comments on that? No? Excellent. All right, so we're gonna discuss blood pressure goals in a little bit, but something that that struck me as being quite different between the two groups is in the ERC guidelines, you guys have gone ahead and recommended specific vasopressors, inotropes to use in the post-cardiac arrest patient, where on the AHA guidelines they have not recommended anything specific. So maybe just Marcus or Claudio, do you want to maybe walk us through where the specific recommendations came from for those drugs?
Yeah, so there's been a systematic review on what's the evidence for a specific vasopressor or inotrope, and there really isn't much data, so it's very neutral. So the reason why the ESICM and ERC stuck to noradrenaline and dobutamine is probably because they are the #1 vasopressors used in general in the ICU and in the ED. Of course, you all know that there's been numerous studies on inotropes, vasopressors in the ICU, and most of them are neutral. So this is not very strong evidence, but because there's no compelling evidence to do things differently in the post-cardiac arrest patient, that's why we stuck with noradrenaline and dobutamine. But of course, we acknowledge that in the pre-hospital setting, it may be reasonable to give adrenaline if you have that.
Great. Claudio.
I would also like to add that noradrenaline is suggested as recommended by the European Society of Intensive Care Medicine as the first-line vasopressor in septic shock, which is the situation which resembles the most to the post-cardiac arrest care patients because it is a distributive shock and frequently there is a myocardial dysfunction. So this indirect evidence also encouraged us to suggest noradrenaline.
Great, thank you. John, on the AHA side?
And on our review, very similar interpretation that doesn't seem to be clear evidence of one better than the other. Most practitioners are going to use norepinephrine, stateside and in North America for cardiogenic shock and septic shock to get started. So we just didn't specifically say you should use this one. We said literature doesn't give us a clear answer one way or the other.
Okay, thanks. Any other comments? No. All right, let's move on to something else. Let's move on to temperature management, something that's been a source of controversy for a number of years now, but again, slightly different numbers, slightly different recommendations in terms of what people should be doing with their post-cardiac arrest temperature management. Maybe can we start on the, let's start with John and Karen, around the AHA recommendations, which are 32 to 37 degrees for 36 hours.
Yeah, so I think we all reviewed pretty much the same literature. We stole a lot of it from the ILCOR scoping review from 2023. Would note the phenotype of patient that arrests in North America, we have more PEA and asystole than you tend to see that was enrolled in the large TTM trials here, which I think helps sway some of the influence perhaps for ILCOR. But there is some indirect evidence, more in the kind of non-randomized trial sort of realm, that those patients PEA asystole might have worse injury. Those might be the ones who are more likely to benefit from a cooler temperature, not randomized data. So that was part of the reason we kind of kept the 32 to 37 range in there. Would also note, I'm sure we're going to talk about the hours here, and so would note the sub-study off of TTM that looked at a 12-hour duration of maintaining temperature after your bout of temperature management or hypothermia was no different than 48 hours. So we just took 12 plus 24 and called it 36 for the duration of therapy in there. Better data will be coming from IceCap future trials.
I was just going to add a couple of things. The first thing is that the 36 hours is a minimum, and that we actually go through in the supportive text and outline that this includes a period of potential hypothermic temperature control and a period of normothermic temperature control. So the 36 hours is actually the minimum based on the pooled evidence from various different trials. But I agree, I think we all agree that there's uncertainty in specific target temperatures, especially in subpopulations. And that, again, the 36 hours was a minimum, but the sort of true answer of how long someone actually needs this is, I think, still a significant area for investigation.
So for ERC, SICM, so I guess it came from the systematic review that didn't support hypothermia as compared to normothermia. And especially perhaps if you look at the more recent trials with a low risk of bias, the TTM2 study that didn't show benefit from hypothermia. Of course, I completely agree with my AHA colleagues that was a population with mainly a cardiac or unknown cause of the arrest. So it didn't perhaps include so many of the younger hypoxic patients, which we know will get bad brain edema, where you could think that perhaps hypothermia could work. But there wasn't clinical data to show that, and that's why we left it like this and recommend fever control for 72 hours. Claudia, do you wish to?
Well, I would like just to add that finding although the ILCOR consensus does not exclude, there may be some subpopulations that may potentially benefit from targeted temperature management aimed at hypothermia. The only signal came from the Hyperion trial, which has been conducted in Europe, in France, for the precision here, and which showed a significant improvement in the outcome, but it was extremely fragile. It has a fragility index of just 1, and a subsequent individual patient data meta-analysis, which included patients from that trial, plus the TTM2 trial, showed that in patients with non-VF VT, that was the target population of the Hyperion trial, actually there was no difference. So finding possibly there are populations that can benefit from treatment targeted to hypothermia are there, but finding them is extremely hard.
Absolutely, thank you. All right, let's move on to neuroprognostication, and one where I think there may be a little bit more discrepancy across the two guidelines than maybe the last couple topics here. But let's talk about biomarkers for neuroprognostication. And in one case, the ERC the guidelines around how to use biomarkers are much more specific than what we see on the HA side. And maybe you guys could give us a little bit of insight into how those discussions went to come up with the recommendations that you did.
I'll take this in two steps. So I think the first question about how we use neuron-specific enolase in the AHA guidelines is really reflecting what I said earlier, and that we're very constrained by what the literature shows us and tells us. And so the literature tells us that NSE is a valuable serum biomarker for neuroprognostication. When it's high or increasing, that is correlated with poor outcome, but there's significant heterogeneity in lab values, threshold cutoffs, and how this is actually used in practice. And so that is why we said, yes, definitely if it's high, that is supportive of unfavorable outcome, but we're not offering a specific cut point given laboratory heterogeneity and concerns about hemolysis and other things with the processing of the laboratory value itself. We also have added a neurofilament light chain. The rationale for that is that there were several studies that are coming out now. Many of them suffer from the same methodological limitations as all of our neuroprognostication studies, but nonetheless, the specificity was quite high, and the sensitivity was actually better than many of the NSE studies. So again, we don't offer a specific threshold. We don't put it in a specific algorithm, but we did feel that there was enough evidence there to say that this could be a reasonable adjunct to neuroprognostication with NFL, and also because we wanted to really push the field and support laboratories in America getting access to this testing as well.
Thanks, Karen. And Claudio, you guys came up with some more very specific recommendations around thresholds and timelines. Maybe just some insights into where those came from.
Yeah, to parallel the observation made by Karen, these different recommendations also reflect how the guidelines are organized, because AHA doesn't have a specific neuroprognostic algorithm. If you see the guidelines, there is a series of predictors, but unlike the ERC, there is no nodal algorithm with a series of choices. Do you have this? Do this. Do you have that? Do that. And so since we have an algorithm, we need a cutting point in which you change your behavior and you formulate a prognostication. And the NSE with a threshold has been added only in 2020 and reiterated in 2025 guidelines. Initially, we just said high NSE, but we based our analysis on analysis of the individual patient data from the TTM trial. And for other trials that show that despite the apparent dispersion on NSE values, all the values aggregated with a minimal false positive rate around the value of 60. So probably 60 is a reliable threshold. And the good news is that between 2020 and 2025, some studies made in Korea, and some colleagues are here present in the audience, and performed in an Italian community where withdrawal was not performed, show that this threshold works. So potentially the NSE, so generally the algorithm works, and the NSE threshold has been recommended for that reason without specific timing. Concerning the NFL, the reason why we do not recommend it is the same. Since we cannot recommend a threshold, saying high NFL is not very meaningful for us, especially because the heterogeneity in methodologies for NFL is even larger than for NSE, which is normal because NFL is newer than NSE, because there is no recommended clinical assay for clinical use except one, which is only recommended in Europe for now. Obviously, the situation may change. And also because the dispersion of values of NFL is enormous. So in different studies, because of different methodologies, the difference, or within the same study, at different time points, the values of NFL may vary by tens or even 100 times. So since we are unable to recommend a threshold, it's difficult to recommend a criterion for a decision for the clinician. But of course, there is robust literature indicating that the ROC curve of the NFL is good, that NFL is very, very promising, and as soon as we will be able to recommend a threshold, probably NFL will be included in the prognostication algorithm of the ERC and AHA.
Great, thank you both. Claudio, I'm going to throw the next one back to you again to start around secondary prevention, and there's a specific mention or specific focus in ERC around secondary prevention that I know is part of your algorithm. That's not mentioned at least to the same degree on the AHA side. I wonder if you could just explain some of the discussion and rationale behind that.
Yeah, the rationale is that in order to optimize the management of the patient, the ERC recommend that these patients who are in the hospital should immediately screen for causes of cardiac arrest unless they are very, very clearly defined. This means that these are patients who did not have, for instance, an acute coronary syndrome. They don't have an ST elevation, they don't have signs of cardiac ischemia, and they don't have abnormalities at the echocardiography. In this case, they should start a diagnostic workup for inherited disorders and management, the risk factors, and they can be assessed for if they have indication for any ICD, so an internal implantable cardioverter defibrillator.
Okay, thank you. Karen, anything on the AHA side? I know not specifically part of the algorithm, but any comments?
Yeah, I completely agree. Of course, with the clinical practice, it was just outside of scope, and there's separate AHA and I think American College of Cardiology statements addressing this.
Great, thank you. All right, let's move on to some other key topics. Let's talk about blood pressure management. So again, a couple recommendations around blood pressure management within the guidelines and updated based on new science in this area. Marcus, maybe we'll start with you in the ERC side, but in terms of systolic blood pressure management greater than 100 millimeters of mercury, which wasn't recommended on the AHA side, and then a post-ROSC map of around 60 to 65. Maybe you could just discuss some of the evidence and discussion around those recommendations.
Sure. So there's 4 randomized trials that have compared this standard target of 60 to 65 to a higher target of around 80 to 100 millimeters of mercury. Of course, we can ask, where does this 60 to 65 come from? Well, I guess that's standard ICU practice, to target this. This is very common for sepsis guidelines and so forth. There really isn't any randomized trials who have assessed whether a lower target could be better. So that's why we stick to this. And the 4 randomized trials did not show a better outcome if you target a higher pressure. The systolic blood pressure of 100, that we basically put there because, of course, in the ambulance and in the ED, before you have an art line, this is the only number you will have. And, of course, this hasn't been studied in any randomized trials, but we got some observational data suggesting that probably a systolic of 100 is probably a reasonable target.
Yeah. Thank you. John, any comments from the AHA side? I know the maps are kind of the same, but we didn't discuss the systolic pressures.
Yeah, so it's an interesting way how we each approach this. So again, trials were looking 60 to 65, and so we noted that kind of the median on the lower groups, the less than 70 sort of goal, tended to hover right around 65. So we chose that, and we wanted to stay there because we wanted to create a little more proscriptive, just shoot for 65. It's similar to other ICU disease states, so we're going to go with that rather than giving them the range of 60 to 65. By the same token, we actually, in a little bit of a reversal, because we used to have a systolic blood pressure goal, we actually took that away this time because we said, well, really all the literature is, targeted towards MAP, and it's kind of, we're going to get rid of that one this time. Acknowledging, caveat when you're in the back of the ambulance, you do have to cut bait somewhere, and I think that's a perfectly reasonable systolic blood pressure. It was just, again, the constraints of the interpretation of the literature kind of led us down that path.
Excellent, thank you. Maybe I'll throw this one back to you guys as well on the AHA side, just around the use of ultrasound, and maybe what exactly your recommendations are looking for the use of post-arrest ultrasound use.
I'm gonna channel my inner jazz for a moment and note, you have to go where your audience is, and so there's a lot of interest in, point of care ultrasound. Caveats being, it's user dependent. The trials didn't actually look at it against a gold standard, but there are instances where it can be very useful for diagnosing the cardiac tamponade, potentially the pneumothorax, et cetera. So we put that in as a, consider it, but also you'll note if you read the fine print, it actually says, there are specific recommendations for who should be doing ultrasound and what sort of criterion you would have. So we don't go that deep into it right here, but in the right hands, might be very useful.
Great, thanks. And Marcus, was there discussion around this topic at ERC?
Yeah, we kind of have it there because considering angiography, then we talk about the risk of having a positive finding on that angiography and the risk of having a myocardial infarction, which is difficult to diagnose. So it's kind of there as well. So of course we don't recommend against it. But I guess the issue here is that, how often will you have a dramatic finding like a tamponade or something else that you won't note with your chest X-ray, or then again the CT scan that we're also going to do. So I guess that was the reason why we didn't put so much emphasis on recommending this to everybody.
Right. No, great point.
I would like to add that
Yes,
ERC strongly emphasize echocardiography. So it's a difference. It's mainly for ultrasound, except echocardiogram, of course.
Great, thanks, Claudio. Karen, maybe I'll throw the next one back to you as well, and just maybe you could walk us through kind of the discussion and the treatment recommendations around the treatment of myoclonus in the post-cardiac arrest patient.
Oh, yes. I'm supposed to tell you time's up.
In 2 minutes. In 2 minutes. You have 2 minutes.
That I'm a neurologist, so I can talk about myoclonus for days. But I'll do it very quickly. So I think we were excited to try and put some sanity around the use of the term myoclonus because it is used heterogeneously in the literature and perhaps in many cases inappropriately to describe very nonspecific findings. So we added a table with some additional, hopefully standardized terminology that also matches up with the American Clinical Neurophysiology Society terminology around this. And I think the important thing, really the takeaway from us, is that myoclonus can have what we call a cerebral or a cortical correlate, which essentially is a seizure because you're twitching and you have abnormal discharges on EEG. Those should be treated. What we don't want people going after is the awake patient who's twitching with myoclonus or myoclonus where you actually don't have a cortical correlate. So the important nuance for us is figure out what kind of myoclonus you're having, figure out with EEG if there's actually a cerebral correlate to it, and then make a decision about whether or not it should be treated based on those findings.
Claudio?
Okay, excellent. I also like the definition that this myoclonus is a seizure. This is extremely important. I just want to point out for our ERC audience that actually the recommendations are exactly the same, even if the management is not explicitly mentioned, because ERC recommends performing EEG in all patients who appear to be unconscious after cardiac arrest, and they recommend treating seizures. And they recommend performing EEG in a patient who has a myoclonus. So let's assume you have a patient with a myoclonus. You perform EEG because this patient has a myoclonus. You detect a seizure and you treat the seizure because this patient has a myoclonus with an EEG correlate, which is a seizure. So you will treat this patient in any case, even if it's between the lines. Okay, but if you read it carefully, this is the same management. What we do not explicitly recommend is not treating the patients with the myoclonus with no EEG correlate, even if we underscore very clearly that myoclonus may prevent the clinician to detect consciousness. This is very, very clearly stated in the guidelines. So we stress the same point the AHA stresses. I would like to take the opportunity for this debate to clarify one point. Does not treating patients with myoclonus means that we do not have to sedate once we are sure that the patient is unconscious? Because I will feel a bit uncomfortable with a clinician not sedating a patient with a myoclonus is not clinically EEG correlate. So just to clarify for our audience, what a clinician should do, try to sedate the patient who's clearly unconscious, has no EEG correlate, but is jumping on their bed. Just
Thanks, Claudio. Do you have?
I would just say this is not in the guidelines, but I think just reflecting the discussion is that, certainly if myoclonus is interfering with medical care, ventilator synchrony, upsetting to families, et cetera, then, there's obviously potentially a role for sedation in those settings. But what we don't want, and I think that, we don't really know the appropriate approach to sedation in a potentially awake or, subclinical consciousness patient. But what we don't want is over sedation, just chasing myoclonus that does not have a cortical correlate.
Great. And this leads super nicely into our last question. Great segue around the timing, no less controversial, around timing of neuroprognostication. And again, some slight differences between the two groups, and I'll just open this up to any of the four of you to have a bit of a conversation around what led to the guideline recommendations around the timing.
I'll just say I think spiritually we are aligned, but what we wanted to account for was that if people are doing a hypothermic temperature controlled target in the United States, that we make sure that we allow adequate time for rewarming, normothermia, and of course sedation and medications that will confound the exam to be out of the system before we're putting our prognostic tests together.
Okay, yes, I agree with Karen. So these differences in timing reflect actually the recommendation regarding temperature control. Since we are recommending just preventing fever, that in many cases may be done with the minimal sedation. Of course, 72 hours from ROSC is adequate to make a prognostic recommendation. And of course, if you intensely have a hypothermic temperature target, there are higher chances that you have the sedated patients, maybe the elimination of drugs may be impaired, so there is a reason for pushing forward the timing for prognostication. If I'm not wrong, in your guidelines, you make a comment saying that in practical terms, this means if the patient is treated with targeted temperature control aimed at hypothermia, performing a prognostic judgment on day 5. Am I correct?
Yeah, and I think we have the algorithm or the figures somewhere in here. But the other thing I would add is that we, again, constrained by the literature, have to take the literature that's available to us. And many of the diagnostic testing that we use for neuroprognostication hits its highest specificity after 72 hours. So if you actually look at the literature that's available to us, and when these diagnostic tests are most specific, they're most specific after 72 hours. And so we didn't necessarily want people to think that, the literature supports this test at or after 72 hours, but I'm going to use it upstream to support recommendations. Again, the constraints of the literature. But yes, agree, spiritually.
Great, thank you. So that I hopefully that was a good summary of some of these slightly nuanced differences between the two groups for everybody. Thank you to our panelists up front here for your insights and discussion around some of these topics. We'll open it up for discussion, for questions. Anyone in the room, please hand up and we'll get to you. And then we have some good questions from online as well.
Thank you to the panelists. I have two questions about temperature control post-cardiac arrest. The first one is for AHA group. You mentioned that at least 36 hours. We know that there are a lot of trial or studies comparing different temperature, mostly 24 or 48. How is 36 hours determined? That's my first question. The second question is for all the panelists. Is there any specific population consideration? Because we know that there have been debates about the study group in TTM trial or other trials. That may be a very ideal condition because the very high bystander CPR rate, very high cardiac cost, and a very high VF the instance. So that may apply to the real world. So there are other studies considering that the urine scoring system to choose certain temperature for middle risk population, for example, RCAST. And there are also other guidelines suggesting maybe if the patient meets the criteria of the TTM, you may apply 36 or 37.5. But if not, you had better choose 32 or 33. So I want to hear the comments from the panelists. Thank you.
So I will apologize. I was perhaps inarticulate earlier about the discussion of timing. Generally, in North America, you get 24 hours of a temperature management strategy. So 24 hours. Then, based on the literature, after that, we're going to continue managing their temperature, for another 12 hours minimum, giving you a total of a 36-hour time epic. So let's say we cool you to 33. You're cooled to 33. You finish that at 24 hours. You need a period of time to warm that patient up. That's going to require, we call it less than 0.5 degrees centigrade per hour. So you need time to warm back up safely and then maintain that. So your maintenance of a temperature management strategy is no less than 36 hours. So that was kind of how we came to that, that number.
So with regards to I was not a part of the TTM2 study, so I can only comment on it from reading the paper. But I mean, it's a large multi-center study, including centers in Europe, Australia, New Zealand, very variable EMS systems, variable ICUs, high mortality, median time to return of spontaneous circulation of 25 minutes. So it's definitely a sick group of patients. There's no doubt about that. And in that study, none of the subgroups seem to support a hypothermic target. Of course, it's constrained by the inclusion criteria, so a probable cardiac cause or an unknown cause. So the suffocations or the drownings or the clear drug overdoses where you have a hypoxic cardiac arrest, they were not included. So I mean, it's a good hypothesis that this could work in this group, but it hasn't been proven in a clinical trial. And the other thing about how to select the patient that sort of would benefit, it sounds great, but I don't think at the moment we have the means to do that. How do we phenotype? Is it EEG, biomarker, miracle score, or something else? At least in the TTM2 study with 2,850 patients, miracle score did not seem to modify the effect of hypothermia.
Thank you for the question. As others are thinking, I'll just give you one from online. It's kind of a two-parter, I think, if I read it correctly. Do you have recommendations around timing intervals for performing a 12-lead ECG after cardiac arrest?
So it's a little bit in the details, but the recommendation is you probably need at least 8 to 10 minutes post-ROSC was kind of the recommended time to get an EKG, because the really ultra-early ones can have ST changes that will, get better in just a couple of minutes. And so there have been some studies looking at the timing. So we said you probably want at least 8 to 10 minutes after ROSC before you're grabbing that initial EKG, 12-lead EKG.
Oh. Marcus?
I must admit that I can't remember what we put in the ERC ESICM guidelines, but I would think 20 minutes. But I completely echo John's comment on this. We need to wait a little bit because there are ST changes that may disappear after a while, and then, of course, make the decision based on a sort of stable situation.
And the second part to this is timing or recommendations around timing of the management of those ECG changes, whether it's a STEMI or not STEMI. What is the recommendations around treatment of those two cases?
So, I mean, that's a great question. So ST elevation, myocardial infarction, angiography, PCI. Even though there really isn't much data to support that. All the data comes from the non-cardiac arrest population. But then the assumption is, would the cardiac arrest patient behave differently? Well, I mean, I guess they could, but we don't have that data to support that. And that's the reason why. Yes, ST elevation, myocardial infarction, PCI immediately. Angiography or PCI if you have the findings to then show that. Then with the other group where you have a perceived cardiac cause, but you have no ST elevation, then there's been 3 studies on this, and there's a 4th one about to be published probably next year. But all in all, probably around 1,200, 1,300 patients included in randomized trials, comparing a early strategy and a delayed strategy. And overall, the evidence is not supportive of a very early strategy. And in fact, if you look at some of the long-term outcomes, it may be that the delayed strategy may even be better. And that's why, for example, the European Society of Cardiology recommends delaying angiography if you don't have ST elevation myocardial infarction.
I think we're going to say the same thing, but yeah, I was just looking at our recommendations. So our AHA recommendations for PCI were updated a bit in the wording, so they look like they're fairly significant changes. But I think again the spirit of them is pretty similar. But what we did say is we agree with European colleagues that for ST elevation, regardless of awake or comatose, that should be an urgent angiography with PCI. But what we put into the recommendations in a little bit more words, which I think is reflected in our European colleagues' algorithm, is that STEMI equivalents also should be a more urgent trip to the cath lab. So if there's recurrent arrhythmias, cardiogenic shock, et cetera, it doesn't have to just be a STEMI, and that those patients should really have early coronary angiography. But in the absence of that instability or evidence of ongoing myocardial ischemia, then definitely agree with the delayed strategy.
I think this kind of mirrors our 2023 update that, moved in that direction, because really those were the exclusions to be in the randomized trial of early PCI versus not. So we wanted to specifically call those out.
Great, thank you. Any last questions from the audience?
Just a small question for the AHA group. Because the suggestion of emergency cardiac acceleration, the previously version in 2020 suggests that if the patient has been put on mechanical support, you had better than a angiogram, but not in this version. Can you explain a little bit about that?
Thank you.
I don't think we do have new recommendations for mechanical circulatory support post ROSC for cardiogenic shock in a experienced system that has resources. We very clearly say not everyone with cardiogenic shock post arrest should have mechanical circulatory support, but in subpopulations and places with experience and resources, it's reasonable to consider it. I think that the timing of when that occurs in relation to these various other cardiac interventions that we're doing for someone who does have cardiogenic shock and malperfusion, we don't specifically comment on that. And I think in practice, it's highly variable depending on the center. So I don't think we have a specific comment on timing of MCS versus PCI, other than to say, PCI in the setting of STEMI or arrhythmia or shock should proceed urgently to emergently to revascularization. And then how those patients get supported with MCS in the interim, I think is very site dependent and not something that we explicitly comment on. Does that answer your question? Okay.
Thanks, Karen. Marcus, anything else? No?
Yeah, the potential subpopulation that may benefit from mechanical circulatory support, according to the study subgroup, are the patients with a relatively mild cerebral injury with ST elevation myocardial infarction, just for a generic guidance.
Thanks, Claudio. I'm going to ask one more from online. I'm going to modify it slightly, so hopefully we can keep our answers a bit short with it. But there's a question around the oxygenation targets, and if there is a timeline that you're more concerned or most concerned about oxygen-free radicals and oxygen toxicity that would help support the lower oxygen targets.
So a very good question. Of course, if we think about this, it's probably going to be in the very early hyperacute reperfusion phase. So 5, 10, 20 minutes after return of spontaneous circulation. I think this is a problem that we're never going to solve, unfortunately, because I think that during CPR, we need as much oxygen as possible. And if we do that, then it's inevitable that we will have hyperoxia when we get reperfusion. I don't think we will have both of those. But the comment for the clinician is that as soon as you can monitor oxygenation reliably with a blood gas, with oxygen saturation, then it's safe to turn it down, to aim for use a lower FiO2.
I think going back to the ROC data and some additional data afterwards from Henry Wang and his crew, it is hypoxemia is bad for the injured brain, so we err on the side of caution and give them 100% oxygen. The data that Henry and ROC had was really, if your initial ABG had a high O2, not bad, but if you let them ride with a high O2 for a long period of time, that was where we started to see a drop-off in survival. So there's probably some, dose dependency of that. 1 hour, if I'm, have a PaO2 of 300, that's maybe not as bad. But if I get to 5 or 6 hours of it, there's methodological challenges with those studies. We can get into that offline. But, short term for an EMS crew, 20, 30 minutes, probably less bad. Keeping a patient in the ICU like that for 6 or 8 hours, that's associated with poor outcome.
Great, thanks, John. Excellent. All right. Well, with that, we will wrap up this session. Thank you to our post-cardiac arrest panelist members. And thank you to the audience in the room for your questions and the audience online for your questions as well. Thank you.